Good morning or good afternoon, everyone. Welcome to the MedSynapse podcast channel aimed at final year medical students and residents. I'm Dr. Enrica, a consultant nephrology, a doctor with long experience in internal medicine and nephrology. This podcast channel was born from the idea of distributing small medicine pills that can also be useful in clinical practice. We hope you like this idea and thanks for your attention.
Good morning, everyone. I'm Dr. Imane. I'm a specialist in nephrology, and today I'll be talking about renal biopsy in kidney disease for adult patients. We'll have an overview of the current indications, technique, and safety. The kidney biopsy is the gold standard for reaching the diagnosis of nephropathy. It is also helping for staging and decide for the treatment. It will give us more information about the prognosis of our patients. The percutaneous kidney biopsy is the best approach, and before deciding to go for it, we will need a good evaluation of our patients. It is also very important to explain the benefits and the risks to our patients, and to have, of course, a consent signed. The most common indications are a new onset nephrotic syndrome in adult patients. But we have also nephritic syndrome, kidney function deterioration of unknown cause, when we have patients with proteinuria 1 to 2 grams, associated or no to hypertension, active urine sediment, when we have systemic diseases with suspected renal involvement, such as lupus, such as ANCA vasculitis, MGRS, amyloidosis, when we have a suspicion of tubulointerstitial nephritis, in a context of drug toxicity or in context of autoimmune diseases such as sarcoidosis or IgG4. It is also very interesting to check and to perform it in case of patients willing to donate for a living donation for kidney transplant when they have isolated hematuria with normal renal function, to determine the prognosis of this potential donor. And of course, we are doing it for recurrent disease activity, in case of relapses or when we are willing to plan a pregnancy in patients, for example, with lupus. So we all know that there are special cases that need more discussion, and some of them, they do not require kidney biopsy. We have the most common case is the long-standing diabetes mellitus with diabetic retinopathy. Those patients usually they have proteinuria, but they don't have indication for kidney biopsy, except if we are suspecting any added cause, of course. We have patients also with nephrotic syndrome with extrarenal involvement in a context or with a high suspicion of primary amyloidosis or secondary amyloidosis. So those patients, we can avoid the invasive procedure. We can go for abdominal fat pad biopsy or rectal biopsy. Unless, of course, if the kidney biopsy is determined to change the management. Then we have the patients with proteinuria also in a context of obesity. So usually those patients, they do not require a kidney biopsy neither. Then we have interesting and special cases in the patients with nephrotic syndrome with normal renal function, but they have PLA2R antibodies positive, antiphospholipase positive, or they have a thrombospodin positive, antibodies positive also. So those patients, usually when they have a normal renal function, we know that we're talking about a primary membranous nephropathy. Of course, there are some cases that we might have positive antibodies, but it might be a secondary cause, so we need to be careful with that, depending on the clinical profile and of the investigations that we requested. What are the contraindications for the kidney biopsy? So the contraindications are really clear. We have an absolute contraindication in case we have an uncontrolled hypertension or coagulation disorder or patients with active infection. Those patients, the kidney biopsy should be postponed. Then we have relative contraindications in patients with small hyperechoic kidneys, less than 9 cm, with chronic irreversible disease, usually, or patients with solitary native kidney. It might be anatomical or functional, but those patients also we need to be careful. Patients with multiple bilateral cysts, or patients with abnormalities of the kidney that might increase the risk of bleeding, for example. Then we have uncooperative patients, or patients in ICU, or patients very anxious. So we need to control all those factors before proceeding. Before the kidney biopsy, it is very important to collect a detailed past medical history and physical examination to rule out any infection signs in the biopsy sites and with the urine analysis. BP should be very well controlled, less than 140/90, and will prescribe laboratory tests with CBC, platelet count, PT, INR, APTT, and in vivo dripping time. In special cases, von Willebrand will be requested and ELA test also. Ideally, and usually we're doing the kidney ultrasound and imaging or CT scan in some obese patients, for example, before the procedure. Of course, it will help us to rule out any hydronephrosis and also to visualize the kidney size and the corticomedullary differentiation and the inferior pole of the kidney that usually we are targeting for the kidney biopsy to make sure that there are no cysts, there are no abnormalities to contraindicate the act. What about the patients under anticoagulation? Patients under antiplatelets or antithrombotic agents, ideally this should be discontinued if possible for at least 1 week before the procedure. It is very important to check the indication of the anticoagulation with our colleagues, hematologists and cardiologists, and to individualize the management depending on the risk of the patient. So patients under warfarin, we will stop it. We will allow the INR to drift below 1.5. We'll bridge with heparin if needed. And patients with intravenous, with IV heparin, it should be stopped at least for 6 hours pre-biopsy. Then, of course, it will be resumed without a bolus and only after 12 to 24 hours if there is no bleeding complications. Regarding the patients on low molecular weight heparin, those patients should have stopped the day before prior the procedure, and this can be resumed 48 to 70 hours after the act for those at high risk of thromboembolic events. Then we have the patients on a direct oral anticoagulant. So same story, those patients, they will stop the medication 1 week before the procedure. Then regarding aspirin, we all know that most of our patients are under aspirin. Ideally, it should be stopped 1 week before, also 5 to 7 days. However, in some occasions, it's indispensable, and we might do it under aspirin knowing and taking into account the high risk of bleeding, of course, for those patients. So it's not considered as absolute contraindication. However, of course, it's preferable to stop the aspirin also 1 week before. Regarding the pre-medication of those patients, so in some patients with high risk of bleeding, we might use desmopressin to prevent the bleeding, even if it's controversial and there is no strong evidence actually to use it. So it might be discussed on a case basis, basically. The patient has anxiety, we might give you an antihistaminic without any issue. So what about the procedure per se, and what is the most frequent approach? So the patient usually is in a prone position with a pillow under the abdomen, and if the patient is pregnant or very obese, we might do it in a seated lateral decubitus or supine anterolateral position. As I said, percutaneous kidney biopsy is usually performed under ultrasonic guidance with local anesthesia. The ultrasound can localize the lower pole site, usually of the left kidney, at which the risk of puncturing a major vessel is minimized. And CT scan can obviously be used in patients with marked obesity or small hyperechonic kidneys not very well visualized. So once we will localize the lower pole of the left kidney or the right kidney if needed, if there are any complication or abnormalities in the left side, we will go for a skin mark to identify where the biopsy needle will be inserted. Then subsequently, we will prep and we will put some anesthesia after a disinfection of the site, and under the ultrasound guidance we can use the spinal needle to locate the capsule of the lower pole of the kidney and to provide enough anesthesia for the biopsy needle tracked from the surface to the inferior pole of the capsule. After a small skin incision is made to facilitate the passage, real ultrasound is the most common approach used to guide then the biopsy needle directly into the lower pole. Ideally, if we can use the semi-automated or automated gun with the 16 gauge needle to perform the kidney biopsy. So usually we're obtaining 2 cores of the kidney tissue. This is what is recommended, and the tissue should be assessed grossly for the presence of glomeruli. So a high number of needle passes, of course, might increase the complication rate. The tissue sample is considered optimal when it contains 15 glomeruli and 2 medium-sized vessel transverse sections. This is so important. That's why we need to check just after the sample with the lens, with the microscope, or with even the smartphone if needed. Then this tissue will go to pathology for light microscopy, immunofluorescence, and electron microscopy. So then what's about the possible complications post-procedure? We know that the bleeding is the primary complication of kidney biopsy. It might be in 3 possible sites: into the collecting system, leading to microscopic or gross hematuria and possible ureteral obstruction. It can be underneath the kidney capsule, leading to pressure, tamponade, and pain. And it can be into the perinephric space, leading to hematoma formation and a possibly large fall in hematocrit. In other cases, we might have a pain in the biopsy site, we might have perinephric hematomas, we might have require transfusion in some cases, we might require an intervention to control bleeding with embolization. In some occasions, unfortunately, we might need nephrectomy, or we have also a 0.06% of death in some cases. There is also one complication that is, let's say, common but usually subclinical. We might produce arteriovenous fistulas, but in general those are silent and resolve spontaneously over 1 to 2 years. If it's symptomatic, then of course we will need embolizations. To conclude very quickly, so we can summarize that this is a safe procedure, and it's the method of choice for diagnosis, staging, and prognosis of underlying parenchymal kidney disease. A preliminary assessment of the and balancing benefits and risks for the patient is essential. Clinical and laboratory investigation associations suggest a predictable histological pattern usually, and in some occasions biopsy might not be required. The nephrologist should be the one who prescribe the renal biopsy indication, and this procedure should be performed in a hospital setting with the presence of multidisciplinary team in case of any complication. Thank you for your attention.